Yes. All right. Good morning. Thank you all so much for being here this morning. We're so glad that you could be here with us. A couple of things before we get started. I wanted to reiterate that we will be recording this town hall today, and it will be uploaded to our website later this week. As you may have noticed, we have you muted. You will not be able to unmute for the sake of order, but the chat line is open. Please feel free to ask any questions or put any comments you have. We'll be taking everything throughout the seminar. So please don't be shy. Anything you have, you can put that in the chat. So I wanted to introduce who we have today. We have Dr. Anna Lembke. She is the medical director of Stanford Addiction Medicine and chief of the Stanford Addiction Medicine Dual Diagnosis Clinic. She is nationally recognized as sounding the alarm on the opioid epidemic. Dr. Lembke educates policymakers and the public on addiction and what to do about it. She is also, fun fact, a featured speaker in the new Netflix documentary, The Social Dilemma. In the film, she discusses addiction to the internet and how it impacts human behavior. We also have Paula Wolfson. She is the manager of the Avenidas Care Partners program, which provides multiple counseling and supportive services to our local community and to long-distance relatives. Paula is facilitating multiple support groups by Zoom and managing a crisis intervention and consult line during this pandemic. If you need to contact her, we will have her information in the chat later. And without further ado, thank you again, and I will hand things over to Paula and Dr. Lembke.
Well, welcome, and thank you for joining us, Dr. Lembke. This is really an honor, and I'm just so glad you could be here today. So everyone, thanks for joining us, and I'm going to just let Dr. Lembke start. We've talked about alcohol and aging and the ideas for today's presentation.
So I'm really excited to be here. Thank you so much for inviting me. I'm really happy to have this opportunity to talk with all of you about this important topic. I want to cover 4 main points, and then I'm really eager to just have an open dialogue. Also, feel free to put questions in the chat as we go along. I'll try to monitor the chat and respond to the questions as they come. If I miss them, we'll backtrack later, and I'll do my best to answer them. So the 4 main topics that I want to talk about is, first, I want to just talk about some broad epidemiologic trends in the field of alcohol and addiction. Then I want to talk about how much is too much, which was sort of the top billing for this talk. How much is too much alcohol and what is an okay amount of alcohol. Then I want to talk about the damage to our bodies from regular heavy alcohol use. And of course, there's lots of different end organ damage, but I'm really going to focus on the damage to the brain specifically, because that's all kind of a silent, insidious effect that we're not as aware of. And then finally, I want to talk about what to do about it. So what are some practical steps that we can take in our everyday lives to try to target this problem in ourselves or in somebody that we care about? Okay, so first, to start with some broad epidemiologic trends. One of the big shifts in alcohol use in our population in the United States is that we're seeing more and more women who are developing alcohol use disorder. And alcohol use disorder is just our medical term for alcoholism or alcohol addiction. So this is a really big shift, because really, since anybody can remember, men have outnumbered women in terms of alcohol problems at least 2 to 1, but as much as 5 to 1 in the last 100 years. So a big shift is that more women are drinking at younger ages and more women are presenting with alcohol addiction. Then the second really big shift is that we're seeing more people presenting for the first time with problems related to addiction generally, and specifically also alcohol addiction, in midlife and in their older years. So the classic pattern with addiction has always been that if you're going to have that problem, it's going to declare itself when you're a teenager or a young adult, when you go off to college, or maybe even before. But if you haven't sort of showed signs and symptoms of addiction in your adolescence or young adult life, that's not going to be a problem that you have, right? So that was sort of the thinking and also the pattern. But what we're seeing more and more of now is, and I'm seeing this in my own clinic, people presenting in their middle years who have always been able to drink in a controlled and safe manner, who without really any particular new stressor necessarily are in middle age coming in struggling with really what is a full-blown alcohol addiction. Similar to that trend, more and more people presenting after retirement who have a de novo or new onset alcohol use problem. So again, people who have been able to drink in a controlled way their entire adult lives, who then retire, and through a combination of not having to get up the next morning and be accountable, being bored, being lonely, being isolated, any number of factors, start drinking more and progress to an alcohol use disorder, alcohol addiction. So those are some big, sort of global and national trends we're seeing with alcohol use problems. Okay, so the second thing I promised I'd talk about was how much is too much. And basically what we're talking about here is, I think, we can all agree that there's a moderate, safe amount of alcohol consumption for the majority of people. As long as, you're old enough and you're not pregnant and you don't have medical comorbidities, alcohol has been around since the beginning of time. It's not going away. And there is what we consider to be a moderate or healthy level of consumption. And that amount is based on the evidence. So there's science to support this. And I want to describe to you what that science is. So in the last 20 years or so, there have been these very large epidemiologic studies where people have been asked, and this is like tens of thousands of people across different countries, how much alcohol do you drink in any given day? And then those individuals have been followed prospectively, which means they've been followed in time going forward, which avoids some of the recall bias we can get into when we ask people retrospectively how much they drank back when, right? So we're saying, how much do you drink on any given day? How many times a week do you drink? And then we're following them forward in time. And we're seeing what happens to their health outcomes. Do they have pancreas problems? Do they have liver problems? Do they get in more motor vehicle accidents? Do they die? Do they get cancer? You name it, everything. And doing those studies, what we have found is that an adult female who drinks no more than 3 standard drinks in a day and no more than 7 standard drinks in any given week is drinking in what we consider to be a healthy range. An adult male who's drinking no more than 4 standard drinks in a day and no more than 14 standard drinks in a week is drinking what we consider to be a healthy or moderate or temperate amount of alcohol. Now, when we get to be 65 or older, that changes for men, but not for women. So for anybody 65 or older, the safe amount is considered to be no more than 3 standard drinks per day and no more than 7 standard drinks per week. And when I say standard drinks, that's very specifically defined as 14 grams of alcohol, which amounts to a 12-ounce standard bottle of beer, 5-ounce glass of wine, or about 1.5 ounces of hard liquor. In your standard bottle of wine, there are 5 standard drinks. So if you're having a half a bottle of wine every night, you're having 2.5 standard drinks. And if you're doing that every day of the week, you're drinking outside of the healthy range. And what that means is that if you look at that graph, once you get outside that healthy range, the risk of all-cause morbidity and mortality goes way up. And it doesn't go up slowly or gradually, it goes way up. So increased risk of pancreatitis, cancer, liver disease, dementia, motor vehicle accident, and early death. if you look at, yes, is there a question?
Sorry, yes. Someone, Jean is asking to please repeat the safe, healthy range for women.
Yes, I will do that. So the nice thing about the safe, healthy range for women is that it doesn't change once we hit the age of 65. By the way, let me just say as a footnote, why are the ranges different for men and women? Because men and women metabolize alcohol differently. And with much shorter drinking careers, alcohol is more toxic to women than it is to men. So women can drink less than men and yet in a faster time develop all kinds of end organ damage. So that's why those safe amounts are smaller. So I'm going to repeat them again. For women, adult women, no more than 3 standard drinks per day. A day is considered an occasion, and no more than 7 total in a week. So if you're having a glass of wine, and a standard drink is a 12-ounce bottle of beer, 1 5-ounce glass of wine, or 1.5 ounces of hard liquor. So if you are having 1 glass of wine a day, and that's a total of 7 standard drinks in a week, you're just at the top of that limit, but that's considered to be a healthy amount. And Martin is giving me the big thumbs up. Thank you, Martin. So yes, adult women, no more than 3 standard drinks per day, no more than 7 standard total.
I have a question about this. Okay. So some of us, and I'm one of these, I'm barely 5 feet tall. I weigh about 105. I'm not a drinker, I didn't grow up with it, but I'm finding under COVID that every now and then a little bit of something is nice. But I drink that much of wine or that much of a margarita, that's my 2 choices, my fingers get numb pretty quickly. So I just notice stop.
Yeah.
Is size an indicator of that sometimes what for somebody else is moderate, it's too much for those of us who are petite?
Yeah, that's a great question, because obviously it makes total sense that a much larger person could drink more theoretically than a smaller person, or could metabolize it. But I have to tell you, these large epidemiologic studies, they didn't really find a whole lot of variation. So on a population scale, and I don't know how many of them frankly assessed for size, but these studies have been repeated in France, in other countries in Europe and the US, and everybody's sort of coming down around the same place, that more than 3 drinks a day for a woman and more than 4 drinks a day for a man just gets you into a risk category. Just boop, you're in a risk category. It's not a switch like that. It's a continuum, but ultimately it's probably not the case that there's all that much difference between a smaller person and a really big person.
Okay.
Now, what there is a big difference in terms of what you feel, Paula, is whether or not you have tolerance to alcohol. So because it sounds like you drink very infrequently, you can have a little bit and have a big impact. But somebody who drinks every day and drinks in larger volumes won't even notice, the little amount that you drink. And in fact, what they may notice is when they don't drink, because they will go into some degree of withdrawal because they're now adapted. They have that process of neuroadaptation. I want to add one more little footnote to those healthy amounts, which is to say that the healthiest people, if you look at all comers, the healthiest people drink no more than 1 to 2 standard drinks per week. Okay, so and by the way, those people turn out to be even healthier than people who don't drink at all. And so there's been a lot of questions, and I have patients come in and all this time and say, well, isn't red wine good for me? And red wine has resveratrol, and that molecule helps with aging. And this has been looked at every which way from Sunday. And the truth is that alcohol probably doesn't have salutary properties in and of itself. The reason that on a population level, people who drink in extreme moderation are healthier than people who drink more or people who drink nothing is probably because in that group of people who drink nothing is a cohort of sick quitters. So these are people who used to drink very, very heavily and now are on, for example, the liver transplant list. So as a population, that skews the graph so that those people appear to be less well as a group. but that doesn't really mean that alcohol is good for you. The other thing that's probably driving why people who drink in extreme moderation are healthier is, again, not that alcohol is healthy, but that people who drink alcohol in extreme moderation probably do a lot of other things in extreme moderation, like exercise, like eating, like working, like all of the things that we know is a healthy lifestyle. So we have a question here. I have a friend who is a female, age 65, and she drinks 2 to 3 glasses of wine every day and is 120 pounds. So again, the pounds, how heavy she is probably doesn't matter, but the fact that she's drinking even just 2 glasses of wine a day means that for her week amount, she's at 14, which really does put her in a risky category. Okay, so even though on a given day she's within the no more than 3 standard drinks, if she's doing that every day, that's adding up to between 14 and 21 standard drinks in a week, and that puts her in a high risk category. And yeah.
So for 3 glasses a day standard, let's just talk about men, and then the standard for men. If they're on blood pressure meds, cholesterol meds, stroke, the typical profile of what a lot of older adults are on, what does that standard range do to medication metabolism in the body? Is there an impact?
Right. So, I qualified at the beginning to say, assuming there are no comorbidities that contraindicate alcohol. So alcohol, the biggest risk with other medicines is other sedatives. So anybody who uses a benzodiazepine like Xanax, Klonopin or Valium, anybody who uses a nightly sedative like Ambien to sleep, anybody who's taking an opioid for pain, that does put you in a higher risk category and means that there can be drug-drug interactions, which means that you should probably think of yourself as maybe even needing to drink less than what we consider to be the upper limit of healthy. But we don't really have good studies on what that less should be, but you should be aware. And then obviously other comorbidities, if you have obstructive sleep apnea, if you're obese, if you have diabetes, all of those things will probably put you in a higher risk category, but we don't have a lot of robust data on that. So does that answer your question? Yeah, so for men, so this is for men under the age of 65, no more than 4 standard drinks a day and no more than 14 standard drinks a week. So it's an and. So it's not either or, it's an and. But once men are older than 65, their numbers revert to female numbers, no more than 3 standard drinks per week and no more than 7 standard drinks per occasion. To me, an easy way to remember it, honestly, is to say to yourself, you know what, if I'm a woman, I really shouldn't be having more than 1 glass of wine a day, or I shouldn't have more than 1 beer a day. And ideally, it would be good if I had some non-drinking days in there. And every once in a while, on a special occasion, I might go to 2 standard drinks a day. For a man, I think, over 65, it's the same thing. Younger than 65, you should say to yourself, I really shouldn't be having more than 2 drinks a day. And I really should have some non-drinking days in there. So I think those are kind of general good rules of thumb. A woman, no more than 1 drink a day, and ideally a couple days in the week when you're not having anything to drink at all, maybe a rare occasion when you have 2 drinks. And a man, no more than 1 to 2, as long as you're younger than 65, and some non-drinking days. All right, so if there aren't any questions about that, I will go on to the next thing that I was going to talk about. Does that sound good? All right, good. So the next thing I was just going to talk about was what's the damage? Why do we have to be careful with alcohol? And the truth is that alcohol itself isn't toxic. It's the metabolites of alcohol, especially acetaldehyde, that's so toxic on our organs. And I'm really going to focus in on the brain, but obviously you guys know about the liver and you know about the pancreas. The good news is that in the early stages of end organ damage due to alcohol, it's reversible. So for example, if you look at somebody who drinks more than they should, and you look at their liver in the early stages, what you'll see is an infiltrate of fat cells in the liver. It's called fatty liver. And if they keep up that behavior, you'll see an infiltrate of immune cells trying to kind of fight off the damage. But if they were to stop drinking at that point, all of that would go away. The liver has an amazing capacity to regenerate itself. But at some point, the stress is too much, and then that liver tissue starts to scar down and collapse on itself. And that's what we call cirrhosis. And once that happens, it is irreversible. So the liver is a big organ, and there's a lot of room to scar and still have some reserve. But at some point, and sadly, it's not like you're really necessarily feeling it, right? That's the scary part. But at some point you just tip over the edge, and then you don't have any liver reserve, and then you will die unless you get a liver transplant. Something kind of similar happens in the brain. So not so much with the fatty infiltrate, but there are really three main ways that alcohol that we are familiar with can really adversely impact the brain. So the first one is that I want to talk about is something called Korsakoff's dementia. So what happens is that the alcohol causes a gradual loss of function, cortical atrophy in the brain that is due to a thiamine deficiency. Because what happens when you drink a lot of alcohol is that you can't absorb thiamine in your diet. Thiamine is the same thing as B1. And without thiamine, you will get this damage to the brain. Drinking isn't the only thing that causes Korsakoff, but it's one of the main offenders. And you get a destruction of your mammillary bodies, you get cortical atrophy, and essentially you get a kind of a global dementing process that is unfortunately irreversible. The other thing that can happen is something called cerebellar atrophy. So you remember your cerebellum is sort of back here in the back of your head. It helps us balance. And one thing that's classic for an end stage alcohol addicted person is they walk with a very wide gait and they have poor balance and they're prone to falls. And that's because of damage to the cerebellum that can be unique to alcohol. But even on a more subtle level, alcohol can lead to the neurobiological changes that cause addiction. And I want to talk a little bit about how that happens, because it can happen on a spectrum. It's not that it's like, you have to drink a whole lot of alcohol and sort of be living under a bridge to have this problem. People can be really high functioning and in a really stealth way develop an addiction problem. And so before I explain to you the changes in the brain that go along with addiction, I want to just briefly summarize what is addiction? How do we define it? Okay. Because interestingly, we don't define it based on the amount that people drink, because you can be addicted and drink maybe not as much as somebody who is not addicted. That's not typical. It's highly correlative with dose and duration. So the more you drink and the more often you drink, the more likely you are to be addicted. But we don't define it by amount. Amount is just a correlate. So the broadest definition of addiction is the continued compulsive use of a substance despite harm to self and or others. So I'll say that again, the continued compulsive use of a substance despite harm to self and or others. And the shorthand way to remember the diagnostic criteria for addiction is something called the 3 C's: control, compulsion, and continued use despite consequences. So how does control manifest? That means, I told myself I was going to sit down and just have 1 glass of wine for dinner. And yet there I found myself 2 hours later having finished the whole bottle. So that's one example of being out of control in your use. Or telling yourself, I'm going to cut back. I don't feel it's healthy. I want to drink less. And yet, despite your best efforts to cut back, not being able to. So that's the control piece. The other piece is the compulsion piece. So that means a whole lot of mental real estate occupied with thinking about using, maybe hiding the use, getting over the use. Also a certain level of automaticity, like I don't really want to use, but I find myself using. That's the compulsion piece. The last C stands for continued use despite consequences. And this is really the sine qua non of addiction, that even when alcohol is causing interpersonal problems, professional problems, legal problems, health problems, right? My doctor telling me, gosh, your liver's not looking good, or gee, your memory's impaired, I still don't cut back or stop my use. Sometimes that's because I'm in denial, right? So denial is a symptom of addiction. It's not just a river in Egypt. And denial means that I'm just not aware or admitting to myself that I have a problem. But addiction can also occur in the context of people being fully aware. I have many patients who know they have terrible addiction and they still can't stop. And that's, this kind of vortex that is so insidious and so powerful that people can get into. So what is happening in the brain when people get addicted? I think the easiest way to understand this, and it's also the way that I've sort of condensed and understood the neuroscience of addiction in my own brain, is to imagine that in your brain, there's a balance, okay? And when we experience pleasure, the balance tips one way, and when we experience pain, the balance tips the other way. And it's good that we have that balance because we're evolutionarily adapted to approach pleasurable things and avoid painful things, right? But here's something about that balance. It wants to remain level. It doesn't want to be tipped to pleasure or to pain for very long, because then we wouldn't be ready for the next threat, or we would sit around, eating berries and not take care of business. So it's part of our homeostatic or re-regulating mechanism to bring that balance level again. So when I drink alcohol, that goes on the pleasure side of my balance, assuming alcohol is something that gives me pleasure, okay? And my balance tips to the side of pleasure. What's happening in the brain? Basically, there's a part of my brain called the motivational or reward pathway. And when I drink alcohol, I get a release of dopamine, which is my pleasure neurotransmitter in that part of my brain. Okay, dopamine is not the only neurotransmitter involved in pleasure, but it's probably the final common pathway for all addictive substances. The difference between things that are addictive and not addictive is how much dopamine they release, right? And things that are not addictive really don't release much dopamine. Like I've never seen anybody get addicted to broccoli. Okay. So what happens after I drink alcohol? My balance tips to the side of pleasure, but immediately my brain kicks into effect and wants to bring me level again. And it does this by something called neuroadaptation. And I always imagine this as these little gremlins hopping on the pain side of my balance to bring it level again. But the gremlins don't get off right when I'm level. They tip slightly to the side of pain. And that's the come down after having had a pleasurable experience. Now, they don't stay there very long. They get off, right? And then I'm balanced again. But while they're over there, I can experience that as craving, right? Not wanting that good feeling to end. The urge to have a second or a third or a fifth drink in order to maintain that good feeling. If I just wait long enough, the gremlins will hop off and I will have a level balance. That's an isolated occurrence, kind of a condensed metaphor for what happens in the brain. But now imagine that you repeatedly ingest an addictive substance again and again and again on the pleasure side of your balance. Now I need a whole room full of these neuroadaptation gremlins in order to bring my balance level again. They tip me to the side of pain. And when I'm not drinking, guess what? Those gremlins don't hop off. So I'm in this persistent state of craving and wanting. And that can go on for days and even weeks, and in some cases, months, which is why it's so hard to stop using once we become addicted. I know for me, I sort of had an aha moment in terms of understanding why would people go back to drinking when so many bad things are associated with that behavior. And when they stop, they can see everything gets so much better. But I realized from the neuroscience that it's because they're walking around with a balance tipped to the side of pain, which is driving this physiologic craving to use just to bring the balance level and feel normal again, not necessarily even to get high. So that's how I think about when we get into that addictive place where we have this physiologic and psychologic compulsion to use. What's really happening is that we've essentially by ingesting all this external dopamine in the form of alcohol or other drugs, we downregulate our own dopamine and our own dopamine receptors. So we essentially put ourselves in like a depressed state, a dopamine deficit state. And that makes us feel really lousy, and we don't enjoy anything else. And the only thing that makes us feel good is that going back to that alcohol. So if you start to notice that type of thing, then you're starting to move toward a kind of an addictive place, which is different, although related to drinking more than is healthy for you, right? Because we're talking about what's going on in the brain. I have a lot of people who come to me and they say, Dr. Lembke, I'm here for help with depression, anxiety, and insomnia. And I say, I want to help you with that. Tell me about your alcohol and drug use. And they say, well, I drink about a half bottle of wine every night. So doctor, now that you know everything about me, what are you going to prescribe for me to make my depression and anxiety go away? And I say, I'm going to prescribe that you abstain from alcohol for a month. Why on earth would you do that? The only reason I'm drinking is because I'm depressed and I can't sleep. I said, that may be true, but you have now basically put your brain into a dopamine deficit state such that, number one, you probably are depressed and have insomnia because you're drinking. You're like this, right? And if you stop drinking for a month, you will find that your balance resets itself. And with us not doing anything else, you'll feel better and you'll sleep better and you'll be less anxious. And I have to tell you, I am such a convert to this. I've been practicing psychiatry for 25 years. I started out prescribing a lot of pills and doing a lot of psychotherapy. Some of my patients got better. A lot of them didn't. Now, when I have a patient come to me with those same symptoms and they tell me they drink every day or they use cannabis every day, even if it's not that much, my very first intervention is, I want you to stop that for an entire month and then come back and tell me how you feel. And I say to them, I predict that in the first 2 weeks, you're going to feel worse. So I'm asking you to do something that makes you feel actually worse. You're going to sleep worse. Why? Because the gremlins don't hop off right away, right? But if you can make it to the full 4 weeks, you may be very surprised to discover how much better you feel. And 80% of folks come back less insomnia or sleeping like babies, less depression, less anxiety. So I really urge you, even if you are not in a risky drinking range, to consider the potential impact of even a single or a couple of drinks per day on your general well-being, because this is the more subtle effects that we can see on the brain as a result of daily alcohol use. I'm going to stop there and see if there are any questions before I talk a little bit more. I've sort of given you a little prelude to what to do about it, but I'm going to just stop here and see if there are any questions.
I have a question. So why don't we try to explain to people what alcohol dementia might present like?
So alcohol-related dementia, we used to think it had a very specific presentation of a specific type of what's called anterograde amnesia, where you don't remember things from the onset of the dementia. But actually, we don't think that anymore. We think you can get a kind of a sort of a global memory loss that can be both immediate memory and past memories when you have alcohol-related dementia. Sometimes there can be something called confabulation, which is common with alcohol-related dementia-Korsakoff's, which is people have sort of gaps in their time, either because of the dementia or because of alcohol-related blackouts. Blackouts are periods of time where people appear to be awake, but are actually so intoxicated that they have no idea what's going on. I had a patient recently who drove from California through Nevada in a complete amnestic blackout state, a young man. So it doesn't just happen to older people. But what can happen with dementia is then we fill in those gaps with made up stories that we believe are true. So that's another way that it can present, sort of made up stories called confabulation, a sort of global dementia. Sometimes it's associated with like a flatter affect, but not necessarily. So it's not that easy to distinguish, honestly. in terms of the phenotype or what you see from other types of dementia. The real hallmark is going to be radiographic images plus the history of heavy alcohol use, especially in the context of a thiamine or a B1 deficiency, which is there when there's global malnutrition. If you're somebody who drinks regularly, even if you're drinking in a safe range, one thing you might do is make sure you're getting enough thiamine, because thiamine absorption is potentially compromised when people are drinking, on a regular basis.
Okay, I'm going to take this in a little bit of a different direction, but I know you'll be able to help us here because this happens a lot, and I'll explain to my callers, and some of them know this, and I've shared this with people. So I get phone calls on my crisis intervention line from the relatives in New York that 80-year-old mother, grandmother is now in the ER. She was brought in, she was found wandering, confused, and she's being worked up, blood tests, and she's intoxicated. And so the relatives are calling me to arrange home care, which I'm not going to do. I'm going to talk about a safe discharge and what does all of this mean. And a lot of people don't know this. How is an older person worked up in the emergency room if they come in intoxicated and they're actually on a 5150, they're on a hold?
Well, I don't want to speak for every emergency department.
Right.
One of the things that unfortunately is common when people present intoxicated to an emergency department, no matter their age, is to just basically wait until they're sober enough to leave without much of a workup at all. And part of that is because for most of modern medicine, we haven't really considered addiction to be an illness. And so oftentimes we don't have an infrastructure to treat people with addiction. I mean, I would hope that an older person presenting this way, there would be more of a workup, and I'd be curious to know, what that person's experience was. But often there's very minimal workup or recognition. However, if there is obvious impairment of memory, what they will do usually, hopefully, is give IV fluids along with IV thiamine to make sure that that person is somewhat protected from developing this Korsakoff's syndrome, also known as Wernicke-Korsakoff's. Wernicke is the encephalopathic syndrome that precedes the permanent dementing problem. So most EDs will be savvy enough to put thiamine in what's called a banana bag. So it's, sort of a resuscitative liquids along with thiamine to try to present Korsakoff's. Is that what you were getting at, Paula?
Yeah, I'm just curious because I think people assume that if you're in the emergency room and you're intoxicated, you're on a hold, that you're going to end up on a psychiatric unit. And
yeah, I wish that happened more. No, it doesn't. No, it's really hard to get on a psych unit. Really, really hard. There are many more people needing those beds than we have beds to offer them. You'd have to really be, very obvious and extreme to get a psych bed, unfortunately. I think that's unfortunate because I think we have a great psych unit and can help people on our unit. All right, so I see a great note here from Steve, just water today. Good job, Steve. And let's see, Jean. Okay, so Jean also writes a very nice note. And so speaking to Jean's note, I'm gonna, the last thing I really want to talk about is what to do about this problem. And so what I'm gonna ask you all to do is an experiment, because we're a science-informed culture. We believe in science, right? So I want you to do an experiment on yourself. And to do this experiment, you only need two things. You need a pen and a piece of paper, or you need a computer or something to document records. You're not going to document it right now, but I'm going to tell you what you're going to document. So the first thing that you have to do for this experiment is you have to gather data. And here's the data I want you to gather. I want you to write down what you drink, how much of it, and how often. And just keep a daily record. And the reason it's important to write it down is because we ourselves, even in the absence of Korsakoff's dementia, are great confabulators and end up telling all kinds of stories that aren't quite true about ourselves. But if we're forced to focus and write down what we're actually consuming, we suddenly pay attention to it and it becomes real in a way it didn't before. And then I want you to think about, what's my objective for drinking? So I'm sure there are non-drinkers on this call, but I'm just going to assume everybody drinks. What is my objective for drinking? Why do I do it? Things I hear is it's fun. It helps me relax. It makes food taste better. It helps me sleep. It combats boredom. It helps with my depression. It alleviates my anxiety. So many different reasons that people use, but you write down what your reasons are. Then I want you to write down what you notice as problems related to your use. My wife doesn't like it when I have more than 2 drinks. It gives me heartburn. I sometimes wonder if it's making me more depressed. Once I start drinking, I can't stop. The next day, I don't get as much done. I feel tired. Whatever that list is, write down what the problems are. And then what I want you to do is the most important part of an experiment, because to really see whether or not how a system works, we have to press a lever to change that system. I want you to consider committing to 30 days of no alcohol. Now, one caveat here, if you are physically dependent and at risk for life-threatening alcohol withdrawal, you don't do this experiment. You go see a medical professional. But if you're not in that category, and most of us are not in that category, I want you to try 30 days of abstinence. Okay, why 30 days? It seems like a long time. Well, if in the broad scheme of our lifetime, it's not very much. But I asked for 30 days because in my clinical experience, supported by the evidence, it's about the minimum amount of time we need to reset the brain's reward pathway, to have the dopamine sort of reassert itself, to make our own dopamine and our own GABA and our own wonderful endogenous opioids and all those good things, and for the gremlins to hop off and for the balance to be level again. In the first 2 weeks of those 30 days, you will probably feel worse. If you're a daily drinker, you'll miss it. Number one, you'll sort of be like bereft, but you'll also probably have worse insomnia, worse depression, worse anxiety, whatever it is, because your balance is like this, tipped to the side of pain. But if you can get through those first 2 weeks, I would be very surprised if you didn't notice some health benefits at 30 days. And they can take many different forms, from just having more energy, having better cognition, sleeping better. Alcohol has a huge adverse impact on sleep. Helps us initiate sleep, but greatly disrupts deep sleep waves in the middle of the night and toward the morning. Okay, and then I just want you to have a moment to sort of reflect on the role of alcohol in my life, because I'll tell you one thing that's really true about alcohol, and this is what we talk about when we talk about the hijacked brain. When we're using it regularly, we really can't see the adverse consequences. But if we can stop for 30 days and look back, we're much better at assessing cause and effect. And then you can do another iteration of that experiment, which is to say that you can say to yourself, okay, I now want to do, that was so good, I'm not going to drink anymore. Maybe you say that. Actually, most of my patients don't say that. After 30 days, my patients say, I feel so much better. That was great. And now I want to go back to drinking, but I don't want to drink the way I drank before. I want to drink in a different way. Typically, I want to drink less. And then you really map out, okay, I'm only going to drink 1 day a week, and I'm only going to have 2 drinks, or I'm only going to have beer because I find when I drink beer, I don't overdo it. But when I drink hard liquor, I do, or whatever your kind of binding strategy is. And by the way, here's something really exciting. We now have a medicine that can help people drink less. It's called naltrexone. It's an opioid receptor blocker. Interestingly, it makes alcohol less reinforcing. So people find that if people struggle with just limiting their amount once they start drinking, they find that naltrexone helps them drink less on their drinking days and helps them not drink when they don't want to drink. It's not a miracle cure. It doesn't work for everybody, but for some people, it's really great. And we have some other medicines too that can help with this, either stopping drinking or reducing what you drink on drinking days. And then just kind of play around with it. Oh, that worked, or that didn't work. I drank more on this occasion. What can I do differently? And that's kind of it. And we have Liz, I don't know if I should read these out. On my non-drinking days, I like drinking a fruit juice mixed with club soda, delicious. So that's great, Liz. You came up with sort of an alternative, something different to do on the times you would normally drink, a different way to treat yourself. What I'm gonna do now is just go through a series of summative slides that sort of sum up everything we've talked about, and then open it up for questions, more questions if there are questions. Does that sound okay, Paula?
Fine.
All right, so I'm going to share my screen. This won't take very long. This is the great advertisement for the event. So here we talked about how much is too much, what defines risky alcohol use. Doc, I only drink 1 glass of wine a day. Remember, a standard drink is 5 ounces of wine, 12 ounces of beer, or 1.5 ounces of hard liquor. Here are the at-risk categories for, again, this is, so the standard drinks are right here, if you can see this. And then for men under the age of 65, no more than 14 drinks per week or 4 drinks on any given day. For women, more than 7 drinks per week or 3 drinks on any given day. And for age 65 or older, it all just reverts to the female amounts. No amount is safe if you're pregnant or trying to get pregnant. And of course, it's never safe to drink and drive. This is what's called the J-shaped curve. This is what I was talking about in terms of who are the healthiest people. On our Y-axis, we have all-cause morbidity and mortality, bad stuff to our bodies and death. And here we have the number of drinks per day of alcohol consumption. And the big take home from this is just as the number of drinks go up, the curve goes up and the risk of morbidity and mortality goes up. The healthiest folks are people who drink no more than about 1 to 2 standard drinks per day. So right here, or even less, really, it's more like 1 to 2 standard drinks per week. And then you can see this J-shaped curve means that teetotalers, or people who drink 0 amount, are a little less healthy than people who drink in extreme moderation. But that's not because alcohol is healthy. It's because in this group, we have sick quitters. And in this group, we have people who do a lot of things in moderation. Here is a surface rendered MRI from my good friend and colleague, Edie Sullivan, who does amazing experiments on the brain and the impact of alcohol, and also how our brains can recover from heavy alcohol use, which they can as long as we stop with enough time. But this is the brain of a healthy 57-year-old male who has drunk in moderation, and this is the brain of a person with severe alcohol, cerebral atrophy, Korsakoff's dementia. And you can just see the ragtag appearance here and the thinning of the gray matter compared to the healthy brain. This is again a comparison of a healthy control. This is his standing pattern, which is sort of localized right about where he's standing. And I think this is finger nose. This is again from my colleague Edie Sullivan and Dolph Pfefferbaum. And then you can see the cerebellum here. Remember, the cerebellum is that part of the brain that helps us balance. All right, now we have somebody with an alcohol use disorder. Notice the loss of tissue here in the cerebellum. This person probably can't stand up without falling, or probably falls frequently. And then here we have the sway pattern of this person, and this is their finger to nose. This is an example, again, of Korsakoff's. This is the control. You can see the ventricles. There's dark spaces where the cerebral spinal fluid goes in and out. And this is the corpus callosum that connects the right and left hemisphere. See how it's nice and white and thick? And then you get to somebody who is an alcohol use disorder. See how much bigger the ventricle space is here? See this black area compared to here? So as the brain shrinks and atrophies, the ventricles, the space where the liquid around the brain, naturally gets bigger because it has more room to, to kind of float around. And then here you see a thinning also of the corpus callosum in this person with Korsakoff's. So here's a hopeful slide. There's something called a central pontine myelinolysis. And you can see here, that's a loss of the myelin sheath on the neurons in the pons, which is the lower brain stem. And you can see here this area that the red arrows pointing to a loss of myelin. Myelin is white, and so that gray in the middle isn't supposed to be there. But look at this, after a 1-year period of not drinking, these neurons remyelinated themselves. So one of the exciting developments in neuroscience is that we, even in our older years, our later years, we can still generate new neurons, so we can generate new myelin sheaths. There's lots of room for hope. Much of what I talked about today, I discuss in a forthcoming book called Dopamine Nation, Finding Balance in the Age of Indulgence. And amazingly, the experiment that I suggested you try fits perfectly with this acronym dopamine. I don't know how that happened, but it does. Well, it happened because I made up this acronym. But first you want to gather the data, then you want to say your objectives for using, why you use, problems associated with use. Then you want to try this 30-day abstinence trial. First 2 weeks are terrible, second 2 weeks gets better. In that time, you'll develop mindfulness and insight into your relationship with alcohol. And then at 30 days, you'll take the next steps and decide, do I want to continue to abstain, or do I want to reintroduce alcohol, but in more moderation with self-binding? And then you do the experiment again, and you continue to take the data and on like that. All right. I think I'm done with what I planned to say. I hope it was helpful.
Very helpful. And I think Barbara, you got a message from someone named Barbara who wants to know if somebody cannot limit their drinks. Did you see that message?
I didn't. I missed that one.
Barbara, do you have it still posted? Or Kat, do you see it? She basically was asking.
Yeah. What would you recommend to someone who cannot limit their drinks to 3 a week after the 30 days of abstinence? Should they consider quitting completely or getting help?
Great. Yeah. So there's a wonderful nuances in this experiment. So I will say to my patients, if you and I both commit to this goal of abstinence and you're not able to do it, that's also really useful information for us because it tells us that you have less control over your alcohol use than maybe you thought you did. In which case we are going to change our intervention, right? And we're going to consider the possibility that you may well be addicted to alcohol. And that we need to do more. Now, you can be addicted to alcohol and still stop for 30 days. So it's not like being able to stop for 30 days means like, oh, you're good. Because some people just have tremendous willpower and can do it even though they have addiction. But certainly if you're not able to stop, then that raises the possibility that you may have developed an addiction, in which case we need to treat your alcohol addiction. And there's a question I see here about, how to treat alcohol addiction. And alcohol addiction and all addiction is a biopsychosocial disorder. It has biological components, psychological components, and social components. So our intervention is also biopsychosocial. Biologically, we have a lot of exciting new medicines we can help give people to help them drink less or to stop drinking. Psychologically, we know that group and individual therapy directed at the addiction is very helpful. And then socially, peer recovery groups like Alcoholics Anonymous are tremendously effective. We just had a major Cochrane report come out showing that people who actively participate in Alcoholics Anonymous actually have better outcomes than people who get individual psychotherapy. And it's free and it's everywhere in the world. I could do a whole talk about AA and how marvelous it is and how well it works. When I have a patient come into my office and tell me they're either going to AA or they're in recovery through AA, I'm like, thank you, because my job just got so much easier because of that. I realize I missed a bunch of questions coming back, so I'm going to scroll through them again. Thanks, Jean. You're welcome. She says, thanks so much. And also, Jean, let's see, she says, can you tell where the cutoff point between reversible and irreversible? That's a great question, Jean. Without sort of laboratory workup and intense medical workup, it's really hard to know if you kind of cross that line. But if you think you're anywhere close to that line of irreversible end organ damage, it's definitely time to get help stopping. On my non-drinking days, I like drinking a fruit juice. That's great. Someone said, I tried a stringent flavored drink similar to taste of wine. What a clever idea, right? So something that is like, your alcoholic beverage, but not alcoholic beverage. So that works for some people. For some people, that's problematic in this way. Sometimes it can be a trigger for wanting the real thing. So just, we know that we're all kind of operant conditioning in Pavlov's dogs. We all can get craving just by seeing an ad for our favorite drink. So sometimes an alcoholic similar beverage can actually trigger craving for some people instead of being a substitute. So you have to watch out a little bit, but also a great idea if it works for you. That's part of the experimentation process. Someone said, yes.
I just want to tell everybody, we have time. We don't have to rush. And we could go to 12:15, 12:30 if we want, if there's enough questions. So people do have questions, or do you have time to stay on?
I do, and I'm just talking too fast, right? So that's a nice way of you saying, I can calm down and slow down. Thank you, Paula. I will do that.
No, that's fine. I'm usually the New Yorker speaker. I talk fast. So.
All right. Okay, so someone asked, do most people don't care if they drink wine with high blood pressure meds as well as very small doses of antidepressants? So, again, I think if you're drinking in extreme moderation, it's probably okay if you take a blood pressure medicine or even a little bit of an antidepressant. It's all about how much. And I do think, though, if you're taking psychotropics of any sort, especially sedatives of any sort, you really want to be even more thoughtful about your consumption and try really hard to stay into the most moderate use, no more than about 1 to 2 standard drinks per week, ideally. Someone said, what would you recommend to someone who cannot limit their drinks to 3 a week? After that we did that, should they consider getting help? And I would say yes, and I hope I answered that. If not, come back with another question. Someone said, can you describe the impact of drinking on relationships, depression, and stroke risk? So again, if we're talking about an addictive cycle of drinking, really devastating on relationships, one of the most eroding aspects is just the loss of trust, as people with later stage addiction hide their use and live a double life. And then the person who loves them feels that they can't trust anything they say. And so a lot of what we do in early recovery work is actually trying to meet with families and rebuild that trust. It's very challenging. AA has things like Al-Anon, which is for family members of people who are addicted, and that can be extremely helpful, especially to address the complex dynamic of codependency. So codependency refers to this, all families are complex systems, even happy functional families. And when one part of that system changes, then it sort of sets the whole system, makes the whole system more fragile. But one thing that happens as people become addicted is that loved ones, in an effort to help, actually can make things worse by enabling that person. Or they just get in this really horrific dance around, stop, 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 you're ruining your life, you're ruining our family. And then the person sort of stops for a while, and then things are better, and then they start up again, and it's just this tortuous cycle, which is why, family work is really key when you have someone with severe addiction in the family. The other thing was the other question was the impact of drinking on depression. And I hope I sort of explained that heavy regular use can put people in the equivalent of a clinical depression, or what I call a dopamine deficit state. And they can present feeling like they have major depressive disorder, when in fact it's all the alcohol doing that. So there's a very famous study by Schuckett and Brown, where they took a cohort of men who all drank in an addictive way and met criteria for major depressive disorder, put them in the hospital for 4 weeks, and gave them no other treatment except that they had no access to alcohol during that time. At the end of those 4 weeks, 80% of those individuals no longer met criteria for depression. So just by not drinking, their depression spontaneously resolved. Now that means 20% still met criteria for depression. So what I'll say to my patients after the 4-week abstinence period, I'll say, if at the end of those 4 weeks, you're still feeling as depressed as you feel now, that's also really useful data for us, because it tells me that there's a co-occurring depressive disorder that we need to treat alongside treating your alcohol use problem. There's a question here about stroke risk. Alcohol actually can thin the blood and increase the risk of a hemorrhagic stroke. So something to think about. There's something here about Al-Anon and AA meetings helping, and I hope I addressed that. There's someone here saying, if alcohol has any infinitesimal +0 damage to health, I would not want to touch it. With your dopamine point, I can find listening to music to replace a drink a day. So I would just say in response to that, you're really lucky that you don't have, that alcohol doesn't have a pull for you, because it is really hard to avoid it. And once we're addicted, it's so hard to stop. But I can tell you, we all have something that we're addicted to, and that has a kind of, we have an unhealthy attachment to. And in my upcoming book, I talk about what my addiction is and sort of the things that I've had to do to deal with it. And it's not a typical addiction, it's addiction to a certain type of novel, which sounds really trivial, but actually can have really destructive potential in my life. And conceptualizing my relationship to a certain type of reading also helped me find my way to understanding my patients better, because I really think, we all have this human propensity for becoming addicted. And if it's not one thing, it's another. Okay, then my connection has been intermittent. Will we be able to stream this later? I have no idea. It seems even one drink a year would timely damage for a little. Well, I don't know, one drink a year. No, I don't think so. I know we are talking about alcohol. Does sugar or carb craving are similar with dopamine? Yes, it does. And waiting until the craving passes results in more of a mental balance. Yes, so if you have the fortitude to just wait till those gremlins hop off and your balance is level, you'll find that the craving kind of goes away. It's part of why developing mindfulness is so important. So mindfulness is one of those terms that gets tossed around all the time. Like, what the heck is mindfulness? Mindfulness is the ability to observe your own thoughts and emotions without judgment. That without judgment piece is really important, because we're all prone to judge ourselves harshly as well as judge others harshly. And to be able to really observe in a neutral and objective way our own internal experience means that we can't be judging it, because once we're judging it, we're going to be suppressing our thoughts. So what's really interesting with addictive pull is to learn how to use that mindfulness practice to surf the urge. So instead of giving in to the urge, you just kind of go, oh, there it is again. Look at that. I'm having that pull. One of the great acronyms from Alcoholics Anonymous is HALT, H-A-L-T. And HALT stands for hungry, angry, lonely, and tired. So when you're feeling the pull to use something, but you don't want to, and you know it's not good for you, you might stop, practice mindfulness and say, wait, maybe I'm really hungry, assuming your addiction isn't food. But even if it is food, maybe you're hungry, and you need to eat something nutritious. Maybe I'm angry. Maybe that's what I'm trying to get away from. I don't want to look at why I'm so angry at my husband right now, right? Or maybe I'm lonely. Maybe I need to reach out to a friend. Or maybe I'm just tired. Maybe I should just tuck myself into bed and go to sleep. Okay, from Alice, terrific presentation. Thank you, Alice. Another helpful trick to stopping is to associate with non-drinkers, true, and avoid happy hours during the months after stopping or decreasing alcohol consumption. Change activities to increase exercise if medically able to do so. Yeah, so that's such a great point. Part of why we think that Alcoholics Anonymous works is that it gives people a sober social network of affiliates, and it gives people something else to do with non-users and non-drinkers during that time that they would normally use. And absolutely, exercise has been shown not only to increase mood, decrease anxiety, and promote sleep, but actually help people who have become addicted either withdraw from their addictive substance or not use their addictive substance. So exercise is key. Let's see. Okay, yes, it's being recorded. The specific concrete info, timeliness, and actions are really useful. I'm so glad. Thank you, Jean. Say someone may have one drink a week and they go to an event such as a wedding where you may drink more than usual, the impact or event drinking. Yeah, so you're getting at a pattern of addictive use that we do see, which is a binge use pattern. This is some individuals who are addicted. They meet the 3 C's criteria, but they can go days or even weeks at a time with not drinking. But then as soon as they do drink, they get into serious problem. They drink way too much. Maybe they have a blackout. They get into fights. They get in trouble with the law. That's a common pattern that we see, and it's a very destructive pattern. So it is important to recognize if you have a pattern like that you may want to not drink even on a special occasion, or put other barriers in place. I mentioned the medication naltrexone, which is an opioid receptor blocker, which is FDA approved in the treatment of alcohol use disorder. And there's a certain way you can use naltrexone. Instead of taking it every day, you can take it an hour before you're going to go to that wedding where there's going to be a lot of alcohol and where you know there are going to be people drinking and where you would actually like to drink also, but you don't want to drink 4 or 6 or 8 or 10 drinks. You really like to stick it to two drinks. When you have naltrexone on board, people report that it's easier for them to stay within those limits. Is there anything that's good about alcohol? Oh my goodness, if I left you feeling like there was nothing good about alcohol, that wouldn't be good. Of course, alcohol is a wonderful, mild, when it's working, a mild euphoriant and energizer for some people. And to share that with others over a good meal, those are all not bad things. But
the one good thing about alcohol I've noticed in my life was that it does help men to dance.
Okay,
so
there you
go. That's the one thing about alcohol. As long as they're able to keep their balance and twirl you correctly, that has been a good thing.
Yeah, and I'm sure we can find lots of positives from folks on this call about alcohol. But yeah, I know it was, there was in the Daily Post, there was an ad for this talk and it had my picture and this big bold lettering, how much is too much. And then right next to it was this ad for a liquor store with these 2 guys and these giant, oversized bottles of wine. And I thought, wow, no one's going to come to my talk next to that. Everyone's going to want to go to those guys. Look like they're having way more fun. But I hope you had a little bit of fun today.
I do have a question. Do you have more questions? This is one that I get all the time from my caregivers. So husband, wife, loved one's been diagnosed with dementia, Alzheimer's, frontal temporal lobe dementia, an early stage form of this. That person has been drinking. Their culture in that family, they drink. And so we talk in the group about, should they just stop drinking now once they are diagnosed with cognitive change?
Yeah, so I mean, I would be inclined to say yes. And I would also just add that one of the hardest subpopulations that I treat in my practice is older people with cognitive impairment who drink, because part of the recovery from addiction really relies on having an intact frontal lobe and being able to see cause and effect, to do an experiment, make a behavior change, recognize the outcome. And the problem is that people who are demented or severely cognitively impaired actually can't engage in that work. So what ends up happening is that they essentially have to be cut off from alcohol, which can be, seem really punitive and painful. Also, in a lot of retirement homes, I've noticed like the alcohol flows and there are lots and lots of opportunities to drink, and it can be one of the main modes of socializing. So then you can feel very ostracized if you don't do that. So that can make it really challenging as well. And I don't have any good answers for that, except to find the subgroup that's not drinking, or if someone who's in demented, just, not letting them have access.
Barbara says, you are never too old to benefit from abstinence from alcohol. I know many elder alcoholics who didn't stop until advanced in age, and it changed their lives.
Yeah, thank you, Barbara. That is a great point. And it also gets to something that I sometimes hear from people who are older who say, well, I don't really care if I die of my addiction because I don't have that long anyway, and what's the point? But I can tell you that if you die of your addiction, quality of life at the end of life is awful. It's really horrific. And if you can get your addiction under control, you can have such good quality of life, even if you've struggled for many years. So I would just want to, great point, Barbara, really echo that. It's never too late to get into recovery. It's always worth it. And I've seen miracles, absolute miracles happen at the end of life.
Also, if you do drink and there is an assumption, well, eventually if I do, I'll need a kidney or liver transplant. It's not a simple process. I've worked as a social worker on these teams. Yeah. So you have to show 3 months worth. Well, when I was there, three months worth of abstinence and be checked, blood, urine, and go through a lot of evaluations continually to know that you will be able to keep that organ. Because if you're on the list and it goes to you and you don't keep it, you're denying that person who is next on the list the possibility of having an organ and keeping it. So there's a whole evaluation process that takes place and monitoring before anybody's given a transplant.
Yeah, very true. Yes, Ken. Were you going to ask a question, Ken? I thought he raised his hand. Let's see. Sue says, do you know of alcohol recovery programs for older adults? Sometimes it's hard to be surrounded by young people with a different lifestyle. Yeah, that's true. I would have to ask my social worker. I don't know of any that specifically cater to older adults, but I know there are, plenty of older and middle-aged people in many of these recovery centers. They're not all, teenage and young adults. And there are a number of really excellent programs in the Bay Area. Altamira Recovery is very good in Marin. Olympia House in Petaluma is very good. So those are just two of the residential programs that, at the top of my head.
Anna, can you tell people a little bit about how to reach you, how to reach your practice, and how the department that you work for works with clients in the area?
Yeah. So I'm on the faculty at Stanford University Department of Psychiatry. I run our addiction medicine dual diagnosis clinic. Dual diagnosis refers to having an addictive disorder and another co-occurring mental illness. I would say the majority of our patients, so all of our patients have some sort of addiction. That's the only requirement for coming to our clinic. Many of them also have a co-occurring depression, anxiety, schizophrenia, ADHD, lots of other eating disorders, lots of other co-occurring disorders. The way to get to our clinic is to call our intake department at 650-498-9111. That's 650-498-9111, and ask for the Addiction Medicine Dual Diagnosis Clinic. I have a number of other wonderful faculty who work in the clinic, and you would either see me or one of them. All of us see patients together with trainees, so fellows or residents, sometimes a medical student, so you'd have to be okay with that part. Usually you would start out with the fellow. These are MDs who are highly trained, but they're just they haven't been in it as long as I have. And then I would come join usually about halfway through the visit, and we would talk about what they found out from you and also what the plan is. What we mainly provide, it's an outpatient ambulatory clinic, so it's the least invasive level of intervention. We can do a kind of a 360 global assessment. Do you meet criteria for addiction? Yes or no, why or why not? What else might be going on? Very often our first intervention is this 30-day abstinence trial. We can give you medications to help with that, see if you can do it or not. And then we rely a lot on our partnering, residential treatments or intensive outpatient. We don't have a residential treatment program here at Stanford. We don't even have an intensive outpatient program. So we're a small outpatient ambulatory care clinic. We do diagnosis and we mainly do med management. We do have a number of support groups that are on Zoom now that are professionally led. We have a mindfulness group, early recovery group, isolation during COVID group. We have some chronic pain groups because we have a lot of patients who are addicted to opioids and have severe chronic pain. We have a seeking safety group we're starting. We're thinking about starting a family group. We don't have that yet. So that's kind of who we are. Yeah.
That's very helpful to know that you're doing all these groups.
Yeah.
That's great. Are you seeing an increase of people coming in because of COVID and also having lost a loved one and prolonged grief and complicated grief?
Not seeing a lot of complicated grief due to COVID in our area, at least in my patient population. Definitely we saw an uptick in patients seeking treatment, especially during quarantine. But that was mainly, my impression, that was mainly due to people having more time to address self-care because so many things were stopped or temporarily stopped during the pandemic. In terms of how people have done with their addictive problems since the pandemic and quarantine, it's been really mixed. I have seen some patients who are doing much, much better because there aren't all the social events and all the triggers that would normally prompt them to crave and use. And I've seen obviously some patients doing much worse because of the isolation and the stress and the uncertainty. And we have had, unfortunately, a couple of young people who died of one of them alcohol intoxication complications, and the other from an opioid overdose. Both of them are Stanford students.
Any tips with the holidays approaching about what to put on the table?
Well, for hosts, what I would say is make sure and have non-alcoholic beverages. And then I've seen situations where people who are hosting are very aggressive about wanting other people to drink and really pushing that on them. Many times that's because that person's either totally clueless about addiction or themselves has an addiction and they don't, misery loves company and they don't want to be drinking alone, and they can normalize their use if everybody is drinking as much as they are or more. So I would say with beverages, I would have like a self-serve beverage area where people can maybe pour their own and have non-alcoholic options, and don't do the continually pouring it for other people. Also, people who are moderating, if you're continually refilling the glass, harder for them to track, harder for them to stick to their limits. So just be respectful that you may have non-drinkers there, or you may have people who you never even had any idea, but who are really struggling to limit their consumption.
Okay, well, thank you. All right, well, any more questions or comments here? We're at 12:14. And so thank you so much. And I will invite you back. We would love to have you come back because I think we would like to talk about opioid addiction, and then maybe when your book comes out. And we could also talk about aging and internet addiction, because that is something we are all now doing under COVID, and it is impacting behavior. And so that's a great topic too. I'm doing these town halls monthly, and we've got them booked through February, and I'm excited. We have Dr. Ayati and Dr. Logan Snyder coming on next month on capacity and cognitive change. Just
Great.
signs and symptoms and testing about that. And then Dr. Marina Martin's going to come on in January to talk about navigating healthcare systems. She's the section chief of geriatric medicine at Stanford. So with Stanford as my neighbor and my community partner, I am so blessed to have so many of you from Stanford join us for these town halls. So thank you, everyone. Thank you, Kat. And have a great rest of your day.
Yeah, thanks everybody. You've been a great audience, great questions, and it was a pleasure. And Sally, thanks for your point about the slides. I'll do that.
All right, take care.